This is Andy Alspaugh from Duke University School of Medicine. This presentation will explore a fascinating group of fungi known collectively as the dermatophytes, the causes of superficial skin infections, and arguably the most common infectious agents in the world. In our pathogen map, the dermatophytes are located within the fungal kingdom, growing as hyphal molds. Our learning objectives for this module are first to review the clinical manifestations of infections due to these fungi, second, to discuss how one might acquire dermatophyte infections, and third, to consider how we diagnose and treat these very common infections. Let's begin with a simple and exceedingly common patient case of a 70-year-old man who is otherwise well, but who comes to see you with scaling and itching of his feet. The symptoms have progressed over several months and include thickening and discoloration of his nails. He has absolutely no systemic symptoms referable to this condition. Your examination of the patient confirms that he is healthy, but that he has well demarcated regions on his feet with scaling of the skin and little underlying inflammation. The plantar surfaces are prominently involved, as well as the regions between his toes. He also has nail changes with thickening and discoloration of the nail plate. This is a classic case of what in common parlance would be called athlete's foot with a fungal nail infection. All of these symptoms are caused by the dermatophyte fungi. Dermatophytes are keratinophilic fungi, meaning that they primarily grow on keratinized human and animal tissue, such as skin, hair, nails, and feathers. This specific ecological niche represents a remarkable adaptation for these particular structures by these fungi. This adaptation also results in a very narrow range of sites where particular dermatophyte species can be found. For example, many of the causes of human infections can only grow on human tissue, and they are therefore called anthrophilic dermatophytes. Other species are able to grow on certain animal species, and they are known as zoophilic. Lastly, a small group of these agents can grow in the environment, and therefore they are referred to as geophilic. Now, mycologically, these fungi tend to grow very slowly on artificial growth medium in the microbiology lab. Specific species can be identified using the identification of structures observed during various times of their growth development. Here we are demonstrating various fungal features that distinguish some of the most common dermatophytes that cause infections in humans. For the sake of this presentation, it is likely sufficient that you just recognize a few common dermatophyte genus names, including Epidermophyton, Microsporum, and Trichophyton. Once these fungi establish an infection on human keratinized tissue such as skin, how do they result in symptoms and disease? Most of the symptoms of dermatophyte infections are not due to fungal invasion, since these organisms typically only grow in the most superficial layers of the skin, such as the stratum corneum. They rarely invade deep dermal structures. The local irritation and skin scaling occur as a response to fungal metabolic products produced during microbial growth. Although dermatophytes can be transmitted by direct physical contact, these agents are typically transmitted in what are referred to as fomites, or the desquamated skin and fallen hairs of infected people. And we can all come into contact with these fomites in many areas of the environment. However, some of the most famous sources for transmission include hotel carpets, locker rooms, and swimming pools. Infected hairs are often found in shared hats and brushes, poorly washed bedding, and either theater or airplane seats. Let's review some of the common terms that patients and physicians will use to talk about dermatophyte infections. Now, patients will often refer to dermatophytosis of the body as ringworm. Now, although this infection is not truly caused by a worm, this older term does describe some of the most prominent features of these infections. The infection will often appear as a well-demarcated patch with a minimally inflammatory border, containing a region of central clearing with skin scaling, thus the ring of ringworm demonstrated in this image. Other terms include onychomycosis, indicating nail infection due to the dermatophytes. As demonstrated in this image, onychomycosis typically presents as a chronic and painless thickening of the nail plate with an accumulation of scaling debris in the nail bed. This debris often includes a mixture of human and fungal elements. Other terms will define the site of infection using the word tinea plus the Latin name of the involved body part. Therefore, tinea unguum refers to dermatophyte infection of the nail or onychomycosis. Tinea pedis refers to involvement of the feet or athlete's foot, as demonstrated in the initial patient case. Tinea manum indicates infection of the skin of the hand. A patient with dermatophyte infection involving the inguinal region and the inner aspect of the thigh has tinea cruris or jock itch, a condition that is almost exclusively observed in men. Dermatophyte infection of the thorax or abdomen is tinea corporis or ringworm. A particularly troublesome type of dermatophytosis is tinea capitis, or involvement of the head and scalp. This condition occurs most commonly in children. It can be somewhat difficult to completely eradicate, and it can also result in some degree of hair loss, as demonstrated in the top image on this slide. When the infection results in tissue inflammation, the lesion is called a carrion. Because of the deeper involvement of the hair follicles in tinea capitis, this condition often requires systemic therapy as opposed to simple topical antifungal agents. The diagnosis of dermatophyte infections is usually made by its characteristic clinical appearance. However, other conditions can result in inflammatory patches, such as contact dermatitis and reactions to various medicines. One can make a more definitive diagnosis by scraping the involved skin onto a microscope slide, adding potassium hydroxide to dissolve the human skin, and observing the fungal forms by direct light microscopy. The skin scrapings can also be sent for fungal culture if the diagnosis is in doubt. Rarely, biopsy and histopath analysis are needed to diagnose this condition. On this slide, I've attempted to summarize some of the treatment issues for dermatophyte infections. Now, most cases involving the hands, feet, or body can be treated with topical antifungal agents, such as the topical azoles, terbinafine, or naftafen. Treatment often requires at least 2 weeks of therapy and should extend for about 1 week after the symptoms clear to ensure that all of the fungi, even those hiding in the dead layers of the skin, are well treated. It's important to note that topical nystatin, a good agent for superficial candida infections, is not effective against dermatophytes. Also, patients will often use topical steroids for many non-specific skin eruptions, but these agents should be avoided if you are treating dermatophyte infections. As I mentioned previously, tinea capitis often requires systemic therapy to result in a cure. Historically, the oral antifungal agent griseofulvin was used for this condition, mostly due to its acceptable safety profile in children. However, griseofulvin must often be used for 2 to 3 months. In contrast, oral azoles and oral terbinafine likely require much shorter courses of therapy. However, cost and potential drug-drug interactions can be important issues with these newer antifungal agents. One of the most difficult and vexing issues of treatment is what to do about onychomycosis or nail infections. Since these fungi reside deep in the nail structures, and these structures take many months to turn over, one must often treat onychomycosis for several months to have any hope for cure. Topical agents such as azole creams, topical terbinafine, and various antifungal nail lacquers have a low cure rate for this infection, often less than 50% in many clinical trials. However, there are often few side effects from this type of topical therapy. In contrast, oral antifungal agents have a higher cure rate, but prolonged or pulse dose systemic antifungal therapy can be very, very expensive, and some serious side effects have been noted, including liver and myocardial toxicity. One last superficial infection of the skin that I want to mention is not caused by a dermatophyte fungus. In contrast to the intense scale observed with dermatophyte infections, Tinea versicolor often presents as simple pigment changes in the skin without a significant amount of scale or underlying inflammation. It is caused by the Malassezia group of fungi, organisms that require exogenous lipids to grow, such as those present on the surface of your body. This condition is often comparatively simple to treat, responding to topical azoles or anti-dandruff shampoos containing selenium sulfide. And in conclusion, we have discussed superficial infections due to various groups of fungi. Although these rarely invade deeper structures, dermatophyte infections are important for several reasons. First, they are exceedingly common among your future patients, resulting in concerning cosmetic changes in the skin, potentially hair loss, dramatic nail changes, and local irritation. Also, once these infections cause a disruption of the normally protective barrier of intact skin, your infected patients will be at a higher risk for more serious infections such as cellulitis, diabetic foot infections, and bacterial infections of the regions around the nails. Therefore, careful attention to these infections can result in lasting cure and prevention of long-term adverse outcomes.